Welcome to the October webinar for the Award Network. I'm Bianca Frogner. I'm part of the leadership team of the Award Network. I'm also a professor at University of Washington in the Department of Family Medicine, and I direct the Center for Health Workforce Studies. I'm excited to say that Andrea Schwartz will be presenting today on an age-friendly approach to dementia care. She will be introduced in a moment by Megan Gately, but before we go there, I want to just do a little bit of housekeeping as usual. As always, you can find all of our webinars online because these are recorded. So you can find a wonderful library of past webinars on the website, which you can get to via the QR code. We also always want to hear from you about webinar ideas. And on that note, November actually turns out to be an open date. So if you have ideas, please let me know. This happened to be open this upcoming month. However, we have an exciting lineup from thereafter, well into 2026. The next one that we have scheduled is December 3rd, where we are going to have a fireside chat with other members of our leadership team, including Joanne Spetz, the PI of the Award Network, along with Kezia Scales from PHI. And so we're really excited. I'll help moderate that session, but we hope that you all may have questions for our speakers. We hope to have to hear from both of them about what recent policy developments may be doing or what that means for the long-term care workforce. So please look for that and register online, which again, you can do via the QR code. Then we want to hear from you all. Each year, we've been doing a speed sharing round with about 5 to 7 of our network members, where you would each present briefly about some work in progress or recently completed work. So we plan to do that in early January to kick off 2026. We will be sending out an email with opportunity to sign up, and we will then do a review among our webinar committee members and let you know if you are going to be presenting at our speed sharing round. But this has always been a fun, exciting way to see what everyone is doing in the network. So please look out for that email. Hopefully, many of you will be at GSA, and if so, we hope to see you at the Award Network annual meeting, which is slated for November 13th. It's taking place in Boston. There should be, if you haven't already seen an invitation and registration via your email, and if not, please reach out to us. And I've been saying this for the last few months, so this is not necessarily new information, but just want to remind people again that the National Dementia Workforce Study has free and available data. This is so critical in this era. So please check it out. The link is there, and there's a public use file free for download, but there's also restricted use files that can be linked via the NIA linkage program. As always, I want to thank the webinar committee members. I would not be able to, not doing this alone. This whole series would not be completed unless we had a great group of folks behind it. Megan Gately will be our MC for today, who organized this session. And I do want to acknowledge our leadership committee members, many of who are here today. And then also I want to acknowledge NIA, our funder for this series. So without delay, I'm going to ask Megan to go ahead and unmute herself. And Andrea, our speaker, feel free to also bring yourself online. Thank you.
Great. So I am so happy to introduce Dr. Andrea Wershoff-Schwartz today. She and I work together at the Bedford and Boston VAs as part of the New England Geriatric Research Education and Clinical Center. So Dr. Schwartz has in her MD and MPH. She is a geriatrician and co-chair of the VA, the Veterans Affairs Age-Friendly Health Systems National Steering Committee. She's an associate professor of medicine at Harvard Medical School and associate director for clinical innovation at the New England Geriatric Research Education and Clinical Center at the VA Boston Healthcare System. And so I'm pleased to turn it over to Dr. Schwartz.
Thank you so much, Megan, for that introduction, and thank you for having me. I'm delighted to be with you today to talk about bringing an age-friendly interprofessional approach to the care of people living with dementia. And to do that today, I'm going to talk about the age-friendly health system in the context of a clinical case. I'm a geriatrician at the VA, and so most of the patients I care for are older veterans in the clinic. And the case we're going to go through today is an amalgam based on cases that I've seen, but not a real patient. And so Mr. M is 84 years old, and he is referred to the geriatrics clinic by his primary care because his son is concerned about some changes in his behavior. Over the last year, he's retired from driving after a minor accident. The son noticed he's been forgetting appointments, he's been losing weight. And so when we evaluate him using our interprofessional approach, we're worried that these cognitive changes do represent a potential dementia. And we're going to talk today about how an age-friendly approach can help us both in diagnosis and management when dementia is diagnosed. So I actually want to start by just inviting you to use the reaction tool if you have access to it, and give a thumbs up if you are familiar with the Age-Friendly Health Systems initiative. I know some of you may be in health systems that are involved in the Age-Friendly initiative, and some of you may not be, but I'm certainly curious among our audience today how familiar folks are with the Age-Friendly Health System. The system itself was developed as an initiative in 2018 by the Institute for Healthcare Improvement with the support of the John A. Hartford Foundation and the partnership of the American Hospital Association and the Catholic Health Association. And as we'll discuss today, the Age-Friendly Initiative is focused on 4 M's: what matters, medication, mentation, and mobility. And during our presentation today, we'll go through the evidence behind each of these M's and how we can apply them to the care of people living with dementia. And we'll talk about the importance of the 4Ms as a set and the synergy between them, especially when it comes to caring for people with dementia. So the many institutions that have partnered around the Age-Friendly Initiative were joined by the VA in 2020 when it sought to become the largest integrated age-friendly health system in the country. These are the goals of the age-friendly movement. The idea is that there should be no wrong door for an older person to receive evidence-based care that is based on geriatric principles and is aligned with what matters to them and their family, and that it should really be a path to avoiding harms from the healthcare system, which we know people living with dementia are so often at risk for harms from encounters with the healthcare system. The way that the 4Ms were developed is based on 90 features identified in many different high-level, rigorous studies that looked at different geriatric models of care. And what many of these different programs had in common is they were trying to reduce hospital admissions, reduce polypharmacy, avoid falls, align care with goals. And when all of those different elements were studied, the IHI and John A. Hartford team came up with the 4Ms as the vital few. And so we're going to be talking about how those different care models that boil down into the 4Ms all come together to help a patient like Mr. M in the care of people living with dementia. So we're going to start by diving into the mobility M. And in an age-friendly health system, mobility is broader than just preventing falls. We know, in fact, that a too narrow focus on preventing falls can actually lead to a decline in mobility by discouraging people from getting the movement and the exercise and the physical activity that they need. And so mobility in an age-friendly approach is about making sure that older adults can do what matters to them. And especially for somebody living with cognitive impairment or with a dementia diagnosis, mobility is the difference between being able to participate in life activities or having their life space be shrunken due to their cognitive impairment. So in Mr. M's case, we already have a sense that his mobility is becoming an issue. He's retired from driving, which leads to restricted mobility and even depression in many older adults, if not met with a plan to help them get to where they want to go. He's been forgetting appointments, which may point to difficulties with mobility in terms of navigating both public transportation or private transportation, which can be affected by cognition. And if he's losing weight, he may be losing muscle mass, which will put him at higher risk for falls. And so often when people present with dementia, we see weight loss as an early symptom as it becomes more difficult to plan meals and manage meals, which is a very complex cognitive task. In an age-friendly approach for each M, we talk about assessing and acting on each M. And when it comes to mobility assessment, there are many evidence-based tools that clinicians can choose from. Most of them have simple instructions and so are easy to adapt to people living with dementia. Although some mobility assessments have more complex instructions, such as the SPPB, and so may need adaptations to be able to be applied in somebody with dementia. But when we talk about assessing mobility, this is something that needs to happen in every setting, whether the person is being evaluated at home, in an outpatient clinic, in the hospital, or in a nursing home. And that's because if we don't know our patient's baseline mobility, then we don't know how to work to maintain it or even improve it. And that's again why we talk about mobility in an age-friendly approach being much broader than falls prevention. And so, in a patient like Mr. M, or someone who's already been given a diagnosis of dementia, screening for mobility limitations that may interfere with doing what matters is critical, as is setting mobility goals that are based on what matters. So a question that I learned from Dr. Mary Tinetti and the Patient Priorities Care Network is asking our patients, what do you wish you could do more of? In Mr. M's case, something that really mattered to him was being able to spend time with his grandchildren and wanting to be able to attend their sports games. For him, that meant being able to walk down uneven ground to get to some of the soccer fields or football stadiums and being able to go up the stairs. So here is our first mention of the critical nature of our interprofessional teamwork. Wherever Mr. M is encountering the system, we hope that he could have a brief mobility assessment. A quick test like a 4-meter walk test or even a chair stand, which we'll discuss, can help figure out how high risk Mr. M might be. Then, collaboration with physical therapists, occupational therapists, and other mobility specialists can help make sure that our patients have the support that they need to do what matters to them. Now, in my work at the VA implementing the age-friendly initiative, a frequent question we ask is, well, how can we more reliably assess mobility? Many teams have a mobility assessment tool that they use, but they often only use it once there's been an issue, once the patient has had a fall or they come in with a mobility complaint. By integrating a mobility assessment into a clinical setting, we can make sure that we don't miss opportunities to intervene before a fall, before a crisis. And so often in someone living with dementia, where the dementia itself poses a fall risk factor, a fall can be the event that lands the person in the hospital or needing a higher level of care. And so in Mr. M's case, knowing that despite the cognitive impairment we're working up in him, what matters to him is being able to get to his grandkids' games. So part of that is making sure he's got the transportation he needs. If he is retired from driving, who can get him there? Is there a family member? Can somebody work with him to set up a system for a rideshare service? There's programs such as GoGo Grandparents that will allow an adult child, for example, to place an order for a ride share or a taxi without the older person necessarily having to interact with the interface, only with the telephone. And so in his case, a first move was to work on his gait speed. We enrolled him in a program in RVA called Live Long, Walk Strong to make sure that he was maximizing his gait and his steadiness and minimizing his fall risk. But when teams come to me asking about reliably assessing mobility, I always encourage them to use methods from the quality improvement and process improvement world, such as PDSA cycles, where you plan and test out how you're going to work mobility assessment into your workflow. And then you actually study what were the barriers, where does it need to fit in the workflow? And you go through these cycles tracking your progress. I'll give one example from my own work. Initially in our geriatrics clinic, we we had very good uptake of the chair stand test. And if you haven't done the chair stand, I like teaching this one because it's both diagnostic and therapeutic. So anybody living with dementia should have a mobility assessment. The chair stand enables you to get a sense of their mobility. If you'd like to try it with me, you're most welcome to. You don't have to turn on your cameras. You cross your arms over your chest, or you can stick your arms straight in front of you, and you actually stand up without using your arms, and then you try to sit back down. And there are age and sex cutoffs for the chair stand that determine how high risk someone is for falls. But what I love about this exercise is it's actually therapeutic. It helps increase muscle mass and decrease the risk of falls by practicing it. So this is a prescription I give to many of my patients while they're waiting to see the physical therapist or the occupational therapist. But in our own geriatrics clinic, in order to reliably assess mobility, we needed to do several PDSA cycles to actually integrate a more robust gait speed measurement into our clinic. And what we found through that experience was that it really took a team. We needed to partner with different members of the interprofessional team to make sure that we were assessing mobility in our patients, so that we were finding opportunities to lower the risk of falls early on in a patient's course. So that's one aspect of mobility assessment, but I want to introduce another one, and this might come as a bit of a surprise. I'm curious how many of you have read Being Mortal by Dr. Atul Gawande. Dr. Gawande is a surgeon here in Boston at Harvard Medical School, and he wrote this book reflecting on the need for geriatrics and palliative care training and integration into our healthcare system. And there's a passage in this book that I love as a geriatrician, where Dr. Gawande is shadowing a geriatrician who is seeing an older person with a lot of multimorbidity, with cognitive impairment, with many medical problems. But the geriatrician spends much of the exam looking at her feet. Is that really necessary? She asked when he instructed her to take off her shoes and socks. Yes, the geriatrician said. After she, the patient, left, the geriatrician told me, you must always examine the feet. Now, one might not think that the feet have much to do with dementia, but I want you to think for a moment what you would do if you had difficulty reaching your feet, and maybe some of us do. Most of us will have difficulty as we age doing tasks like trimming our toenails. So I invite you, where you're listening, to just get into the position you might get into if you were going to trim your toenails. Some of you might have your foot up on your desk, but your cameras are off. We can't see. Some of you may be bending down. Some of you may have your legs crossed over the other. You can probably think of many things that could get in the way with doing this movement as we age. And so in Mr. M's case, he had several medical conditions that made it harder to perform foot care. This is a list from an article by my colleague, Dr. Kirsten James, that gives examples of the many different reasons people might struggle with trimming their toenails as they age. We developed here at VA Boston a physical exam finding that we call the long toenail sign. And this was something that we saw when we looked at Mr. M's feet. The long toenail sign, which we define as when toenails have grown beyond the tip of the toes, is a hidden exam finding that tells us that a patient is not getting the support that they need. And that's because there are lots of mobility reasons it might be hard to trim your toenails. But if you or I had difficulty with this task, we might have a few alternatives. We might ask a care partner. We might go to a nail salon. We might go to a podiatrist. But all of those presume a level of social connection, a level of cognitive executive function to plan out a podiatry visit, a level of health literacy to know that there is such a thing as a podiatrist, a level of financial and mobility and transportation to go to a nail salon. And so my colleague, Dr. Arkabi, and I call the long toenail sign the A1C of functional independence. You may know the A1C from diabetes, that it's a lab test that tells you how the sugars have been controlled over the past 3 months. Well, we argue that the long toenail sign, which takes 3 to 6 months to get this long, maybe even longer, is a sign that over the past few months, Mr. M has not been able not only to trim his own toenails, but to access the care that he needs. So this physical exam finding told us that the son was right to be worried, that Mr. M likely had issues not only in his mobility, but probably needed more support to be able to adhere to his healthcare plan and to make sure that the caregiver had the support that they needed to help support him. So, as we're going to see as we go through the rest of Mr. M's case, once we see a finding like this, we know this is a patient that is going to need an interprofessional team. And we can think very broadly about the types of interprofessional team members that will be critical over the course of Mr. M's trajectory. Not all at once, but over the course of years, we involved all these different team members. And so I'm going to give you a flavor of how this plays out in Mr. M's case, beginning with how we handled this finding of the long toenail sign. Well, first of all, at the VA, we're lucky to have an excellent podiatry department. So that was a first move. We referred him to our podiatry department. But we also looked at the long toenail sign as a sign that perhaps Mr. M was having difficulty caring for himself at home. And when we asked him what matters, in addition to spending time with his grandkids, staying independent was extremely important to him, as it is for many Americans. And so, with his permission, we were able to involve his son and discuss with him about considering getting more help in the home to help prolong his time at home. The next thing we looked at was his mobility. And he had a very slow gait speed. He had difficulty with the chair stand. He had limited vision and dexterity. So over the ensuing months, he worked with physical and occupational therapy to maximize his function. And we actually sent him to the eye clinic to update his prescription because that was also contributing. As we'll see when we go through the 4Ms, they all play a role, and we do have to consider them as a set. In Mr. M's case, when he bent over to pull on his socks or trim his toenails, he was getting dizzy. And so we were able to titrate his blood pressure medicine and deprescribe unnecessary anticholinergic medicines that could have been making him dizzy, as we'll see later in the talk. But the biggest takeaway from this physical exam finding was not just about Mr. M's mobility, it was about his mentation. Because 10 years ago, he would have been able to navigate the healthcare system, to ask for a podiatry referral, to get there himself. The fact that he was not able to do that made us worried that we were really dealing with cognitive impairment that was affecting his function. And we needed to rule out potential medical causes, but we were worried that he might have dementia. And so while we pursued our cognitive and mood assessment, which I'll describe, we also sent him for an audiology referral because it's certainly not a fair test to do a cognitive assessment if you've got hearing impairment and don't have working hearing aids. In his case, he had wax in his ears too, so we were able to prescribe some Debrox drops and get that cleared, which is often a very important intervention we do in our geriatrics clinic because the wax in our ears gets thicker as we age, and sometimes that is nobody looks in the ears and patients are walking around not able to engage cognitively with the world around them. So this gives you a flavor about how the 4Ms as a set could help us address this interesting physical exam finding of the long toenail sign. I'm going to move us on now to the next M, but I invite you as we go, you're welcome to type questions into the Q&A, and we'll have an opportunity at the end to address them. But certainly if we do see questions coming in during the talk, I'm happy to address them as we go. So we're next going to look at Mr. M's mentation. And in an age-friendly health system, when we talk about mentation, we're of course thinking about dementia, but we're also thinking about 3Ds, delirium, dementia, and depression. And we know that people living with dementia are at much higher risk of delirium, which is that acute confusional state that is often transient or reversible, often in the context of illness, infection, a new medication. We also know that people with dementia may present with depressive symptoms, withdrawing from activities, finding less enjoyment, and it's very important to tease out whether it's cognitive impairment or depression or both that is driving a disengagement or a withdrawal, because the treatment for depression is often very well tolerated in older adults. And so we want to make sure that we're not missing a depression, even if there is also a dementia present. Other priorities we think about in an age-friendly health system approach to dementia is thinking about other aspects of mentation, such as suicide prevention, which especially in the veteran population is a major concern and a risk that actually goes up with age. Substance use can also contribute to cognitive impairment. And PTSD is often underdiagnosed and may also have an uptick in older age and be very amenable to treatment if appropriately diagnosed. And finally, as I've mentioned, hearing and vision impairment are so critical to address to be able to give people with cognitive impairment or with a dementia diagnosis the best opportunity to engage with the world around them. So going back to Mr. M, part of what we were trying to elicit as we were getting to know him and trying to make a diagnosis was what might be contributing to his cognitive impairment. And so you can see here some more details of the types of questions we asked. I'll point out a couple that I haven't mentioned yet. One is asking about personality or mood changes, and the other is asking about sleep. So often we see that sleep can be disrupted in old age for a number of reasons. Medical causes such as sleep apnea or REM sleep disorder, as well as medication causes such as being on diuretics that make you wake up and need to go to the bathroom in the middle of the night, or even some of the medications for dementia, such as cholinesterase inhibitors, can cause nightmares or nighttime awakenings. So understanding how sleep is contributing, because we know sleep affects mood and memory, can be incredibly important. In Mr. M's case, it didn't seem that substance use or a history of delirium or head trauma were contributing, and he had a high level of education as well. So these questions help drive our diagnostic workup. And in addition to a lab workup, which was ultimately unrevealing, and head imaging that was also unrevealing, we did some cognitive testing. So many of you are likely familiar with the short mini cog, which is a 3-word recall and a clock draw. And Mr. M's clock wasn't terrible. You can see here that he had all the numbers in place, but the 9 and the 3 didn't line up. And the 12 and the 6 didn't line up, which are often signs of executive dysfunction. And executive dysfunction is what predicts difficulties with managing medications, with driving, with managing appointments. So we weren't surprised by these results. But he got 1 out of 3 recall and wasn't able to pick the words out of a list. And that rapid rate of forgetting made us concerned that he could have an Alzheimer's dementia. Longer cognitive testing, including tests like the MoCA or full neuropsych testing, confirmed that he was most likely dealing with an Alzheimer's dementia. And at our VA, we were able to refer him to our neurology memory clinic, where they could pursue an amyloid PET scan called a Fluor Beta Peer scan, and feel more certainty that it was likely Alzheimer's pathology leading to his dementia diagnosis. But in order to understand what stage of dementia we were dealing with, the next questions we needed to ask went back to his mobility. Asking about our patient's functional status is critical to making sure we understand where they are in the course of their dementia. We typically ask about instrumental activities of daily living first, since it is more common to have changes here initially in the course of dementia. In Mr. M's case, in addition to the retiring from driving, we turned up some safety issues, like a financial scam he had fallen victim to. And so now his son is more involved with his finances. In terms of his ADLs, his activities of daily living, Mr. M was still quite independent. No issues with bathing or toileting or grooming, but his family was noticing that complex tasks like laundry or choosing the right clothes for the season or not wearing the same things over and over were beginning to be an issue for him. And so that brings us to the staging of his dementia. And we often use the FAST scale for staging dementia. It stands for Functional Assessment Staging Tool, because it is really based on that thorough functional history. And in Mr. M's case, that very important difficulty with ADLs, with needing assistance in choosing proper clothes for the day, season, or occasion, puts him at FAST 5, which is moderate dementia. And actually, that's a stage of dementia where we not only continue cholinesterase inhibitors like donepezil, but we also start medications like memantine, which are NMDA receptor antagonists. And so FAST 5, moderate dementia, is the time when we start to see the cognitive impairment not only affecting complex tasks, but also the day-to-day functioning. And so this is the point at which we feel so grateful that Mr. M's son accompanied him to the appointment, because we know that family is going to need to be involved to help keep our patients safe at this point. So in addition to functional assessment and safety assessment, we also need to think about medications. Because it's such a complex task to manage medications, we need to make sure that we've got the safest possible regimen and that we are aware of any other safety behaviors or changes. One tool we can use to find out about these changes is the AD8, which is often used for collateral history. And that can be administered either verbally or in writing to a caregiver to elicit information that can help support a diagnosis of dementia and also understand what potential safety issues could be addressed. So within the mentation bucket, we've talked now about diagnosing the dementia. I'm going to return now to hearing because when we look at the medical literature, we know that of the modifiable risk factors for dementia, elements such as smoking, treating depression, social isolation can make an important difference for treating dementia. But the biggest modifiable risk factor for dementia is actually hearing loss. And too many older adults go through their sixth, seventh, eighth decades without having their hearing assessed and without having the opportunity to address this modifiable risk factor, not only for dementia, but also for depression, for falls. So I mentioned getting the wax out of the ears. Often an audiology collaboration, a referral is a really critical step in people with cognitive impairment because it can help them engage as much as possible. For people who can't tolerate hearing aids, there are also devices such as pocket talkers or pocket amplifiers that may be easier to tolerate or use for more limited times. And now that hearing aids have been FDA approved for an over-the-counter version, they are more accessible than ever from a financial perspective. If you care for any patients who are veterans, be sure to send them to the VA for hearing aids, where usually they're at no cost to the veteran and can make a tremendous difference in quality of life. And I would say whatever care setting you work in, if your care setting doesn't have pocket talkers or some similar device, you may want to look into having them available because the difference between a patient who can engage in conversation and one for whom hearing impairment is standing in a way is tremendously important. And so collaboration with audiology and other hearing professionals is critical. Within the mentation M, the other topic that is critical to think about for people living with dementia is their risk of delirium. And we define delirium typically in hospitalized older adults using these four elements: acute onset, inattention, disorganized thinking, and an altered level of consciousness. The first two are required, and then one of disorganized thinking or altered level of consciousness. And so for Mr. M, one of the things we worried about is that were he to be hospitalized, say with COVID or pneumonia, he would be at high risk for delirium because of his underlying dementia. The more vulnerable your brain is, the smaller a stressor it takes to become delirious. And so often people with dementia experience a sudden decline in cognition or function, and that needs to be treated as a medical emergency and to look for a cause of delirium, which might include a new medication, an illness, or an underlying metabolic abnormality. And so preventing delirium by optimizing Mr. M's cognition is so important. And I'm going to summarize in our mentation section by talking about, again, the importance of assessing for delirium, dementia, depression, using evidence-based tools, some of which I've listed here. And I can't emphasize enough how critical it is that we use evidence-based tools so that we understand where our patients are starting from and can monitor their response to treatment. It's never enough to say, oh, this patient is more confused than usual. We need to understand, are they delirious? We can use tools like the UBCAM and use programs like the HELP program to help minimize the risk of delirium. And finally, thinking about other aspects that may contribute to mentation, such as substance use, other mental health disorders, and sensory impairment. And then we want to act on these findings with our interprofessional team, recognizing that it often takes a team. In Mr. M's case, we had a combination of occupational therapy, psychology, speech and language pathology over the years, helping him in addition to audiology and optometry. And so I've listed some of the resources that we use for managing mentation. HELP is an inpatient delirium program. STAR VA is a nursing home-based program for veterans with dementia to try to help minimize distressed behaviors. That's now also been tried in the inpatient setting. And then, of course, making sure all of our patients know about the 988 suicide prevention line, which also has a special veterans crisis line as well. We're going to now move our attention towards the medication M. And I again want to emphasize how much each M impacts the other. Of course, cognitive impairment impacts our ability to manage medications, and medications can impact our cognition and mood. Of course, mobility impacts our access to medications, and medications can increase our fall risk. And medications ought to be in service of what matters, but often our patients' priorities are at odds with what the medications are addressing. And so as we turn our attention to medication, I want to remind us that while prescribers' attentions are generally so well-intentioned, so often in an older patient, a new symptom should be considered a possible drug side effect until proven otherwise. Sometimes what we need to do for our patients, especially those living with dementia, is take a close look at medications and see if a medication needs to be deprescribed. Sometimes a medication is missing and needs to be prescribed, whether it's medications, say, for stroke prevention, which become all the more important when patients are dealing with dementia. A typical encounter for a patient like Mr. M might involve a prescribing cascade. This is a well-documented phenomenon where an older person or a person on multiple medication presents and is prescribed a new medication for an appropriate medical reason. In Mr. M's case, it was furosemide, a diuretic medication that he needed for his heart failure. However, he showed up to a different clinician complaining of nighttime urination and not making it to the bathroom on time. That clinician took a good history and thought that perhaps the nighttime urination was a type of urge incontinence and prescribed a new medication, oxybutynin. However, the oxybutynin itself had some anticholinergic side effects that led to dry eyes. So Mr. M went back to yet a different clinician and was prescribed artificial tears. The prescribing cascades can continue until a clinician looks and says, wait a minute, the nighttime urination started a few weeks after he started the furosemide. What time is he taking the furosemide? Can he take it mid-afternoon instead of before bed? Does he need to take it twice a day? Could he just take it in the morning? Does he need the same dose? And so often we can avoid prescribing cascades when we ask the question before prescribing a new medication of, is this medication necessary? Other tools we can use for medication safety in people living with dementia are the American Geriatric Society Beers criteria, which provides medications that ought to be used with caution in older adults, as well as safer alternatives. We also want to understand barriers to medication adherence. This picture here is of an easy flip-top cap. Mr. M generally did not have children visiting his home. He would go to his grandparents' home instead. And so the child-safe caps just made it very difficult for him to open the medications. And so it may be more appropriate to switch to a pill box or easy open caps if safe to do so. Another tool I like to recommend is deprescribing.org, which can provide guidance when you do identify a medication that needs to be stopped or decreased. Deprescribing.org provides algorithms and evidence for how to taper them safely and what to monitor for. In the Age-Friendly Health Systems Initiative, the Institute for Healthcare Improvement reviewed the literature, including the Beers list, and came up with a list of the following categories of high-risk medications that should be screened for regularly in older adults, especially in older adults with vulnerable brains. Making sure that we minimize or avoid these classes of medications when possible is critical. This is likely a familiar list to those of you that are clinicians because it speaks to commonly prescribed medications, some of which can be purchased over the counter that are often used to treat distressing symptoms in older people. On the next slide, I'm going to show you Mr. M's medication list, and we'll have a moment to think about which medications could be contributing to cognitive impairment, could be worsening cognitive impairment, and could be putting Mr. M at risk for delirium or falls. So here is Mr. M's medication list, and we took a thorough medication history led by the pharmacist on our team to make sure that we understood all the over-the-counter medications, herbals, vitamins, supplements that Mr. M might be taking. And when Mr. M arrived in clinic, the nurse asked him about how he managed his medications, because keeping medications organized is that instrumental activity of daily living that takes a tremendous amount of cognitive function. So if I were to ask you, which medication might you start with if you were going to try to deprescribe something for Mr. M? And I'm not sure, I don't think I can see chat responses, so I'll just invite you to reflect on which medication you might pick. When I do this exercise, I always like to remind people that when faced with a long medication list, and Mr. M's isn't even that bad compared to many older adults with multimorbidity, often it's useful to match every medication with an indication and to understand why the patient is taking each one. The one that didn't have an indication was the diphenhydramine, also known as Benadryl. This was a medication that Mr. M bought over the counter because of his difficulty with sleeping. We were able to diagnose Mr. M with sleep apnea, which was treated with a CPAP machine. He began to sleep better, which in turn contributed to a slight improvement in his memory, although ultimately he was found to likely have Alzheimer's dementia. Helping address other things contributing to his memory was so important. And so deprescribing the diphenhydramine not only benefited his memory because it can lead to confusion, it also lowered his chance of falls, especially since he was taking it at bedtime. So to sum up our medication section, for a patient like Mr. M, we really want to use evidence-based criteria such as the AGS Beers list and others to identify potentially high-risk medications, try to minimize unnecessary polypharmacy and complexity, and address barriers to adherence. And then we act on our medications by deprescribing as appropriate and working with an interprofessional team. Now, your health setting may have a system for this. At the VA, many teams use the Vione system pictured here. Many emergency departments use the EQUIP system. The most important thing is to pick a system, create a process map of whose job is it to review the medications. And when a high-risk medication is identified, ask, is this still necessary? And make sure that medications are really helping our patients living with dementia to do more of what matters to them. Often it's possible to simplify medications to once daily dosing to make it easier for the patient to adhere to the critical and vital medications and to avoid unnecessary polypharmacy. So I invite you to think about any questions you might have on the medications M. You're welcome to put them in the Q&A as we move to our fourth and final M. And this M is at the top of the circle because it's the most important. It is what all of the other M's are meant to support, which is that our healthcare should be helping our patients do more of what matters to them. And especially for people living with dementia, understanding what's important to them, what makes for a good day, what are they worried about, what do they want to avoid, that is so critical for making sure our care aligns with their goals. So when we talk about what matters, there are often two main buckets we talk about in an age-friendly initiative. The first is advanced care planning, and the second is current care planning. I'll go through each one in turn. You're likely very familiar with advanced care planning because the past 20 years have seen an incredible emphasis on goals of care conversations, on understanding our patients' wishes regarding life-sustaining treatments such as CPR, intubation, and there are many evidence-based programs such as Prepare for Your Care, the Conversation Project, and Vital Talk that help people have these conversations to elicit what matters to them when it comes to end-of-life care and advanced care planning. In Mr. M's case, we used a tool developed by the Institute for Healthcare Improvement that is specifically for caregivers of people with Alzheimer's or other forms of dementia. We wanted to make sure that Mr. M could be involved with the conversation, but that his son, who is his healthcare proxy, would make sure to know his dad's wishes while he was able to weigh in and share his perspective. In Mr. M's case, he had seen a brother go through a very difficult ICU course. And while he was willing to go through a short course of intubation if needed, he felt that if he were so sick he needed CPR at that point, he would not want resuscitation attempted. And this lengthy conversation led to the filling out of a POLST or MOLST form, a medical or physician's order for life-sustaining treatment that meant that Mr. M's wishes could be followed no matter what care setting he's in. And he wouldn't get unwanted care, but only the care that was in line with his goals. But Mr. M, as we mentioned, had moderate dementia. He was likely years, if not decade away from succumbing to the disease. He was much more at risk of having other medical things come up while he was living with dementia. And so to have that conversation, we needed to think about current care planning. And current care planning is a newer term that was popularized by the Patient Priorities Care Initiative, led by Dr. Mary Tinetti and others. What Patient Priorities Care tries to do is help older people with multimorbidity get clarity when they're being told different things by different providers. And so in this infographic, you can see that the Patient Priorities Care approach helps patients and their care partners elicit what their goals and values are so that that can be communicated to their medical teams, and medical teams can align care with goals. So in this patient's case, focusing on medications that help them feel stronger and less shaky, starting physical therapy to improve his strength, and decreasing frequency of lab tests that weren't contributing to his overall quality of life. So in Mr. M's case, going through a patient priorities care conversation helped us figure out what he needed to be able to do more of what mattered to him, spending time with his grandparents, staying engaged with his religious community, and being able to be as independent as possible so he could remain in his home with his wife. Other aspects we consider in the What Matters M include getting to know our patients as people. There are many different ways to do this, and this is one of my favorite parts about being a geriatrician and getting to know people as they age or as they are dealing with dementia. Two programs we have at the VA are called Whole Health and My Life, My Story. Whole Health, as you can see pictured here in the circle, is about understanding the person's medical care as only one aspect of their overall wellness, and really encouraging our patients to be engaged in other aspects of personal development, of spiritual and environmental connection that can help them thrive as they age. In the My Life, My Story program, volunteers interview veterans about their lives and write up a short first-person story that then gets approved by the veteran, and with their permission, it goes in their medical record, and they get a copy that they can share with loved ones. And that way, anyone involved in their care team can know more about their life and what matters to them and what's important to them as they age or as their memory fades. Another aspect of what matters we always mention is caring for caregivers. In Mr. M's case, he was lucky to have an involved son and an involved wife, but neither of them could meet all of his needs. His wife had mobility and cognitive issues of her own, and so while she was able to maintain a lot of the cooking at home, she wasn't able to help with things like medication management. The son, on the other hand, did not have a lot of background in health or medical fields, and so needed a lot of education to understand what to expect with dementia and how to best support his dad. This mnemonic, called Caring for Caregivers, reminds us that when we encounter people living with dementia and their care partners, we want to inquire about caregiver well-being. We want to engage in advanced care planning, which has been shown to reduce caregiver distress. We want to look for opportunities to find respite for caregivers so that they can share the burden of a healthcare system that is not optimized for people living with dementia. And the E is for education, whether that is about resources, about symptoms, making sure that they don't worry alone. Some other aspects to consider in the What Matters M include multi-complexity, such as, and this is often called the fifth M, or the geriatric 5 Ms. And this includes the social determinants of health that affect a person's ability to access care, as well as a person's level of frailty, which, independent of their cognition or their age, can really affect their ability to manage on their own and to bounce back after a stressor. And so a person who is severely frail, when they reach a stressor, they have less reserve. And so they may, in fact, have a much more severe reaction when faced with a stressor. The website eFrailty is a resource we created to help clinicians know which frailty assessments tools to use. And so I'm going to begin wrapping up by summarizing the interprofessional team-based care for Mr. M as we diagnosed him with dementia and dealt with his long toenail sign. I reminded you that the interprofessional team was critical to addressing the 4 M's in Mr. M's case, and that it really takes a team to make sure that none of the M's gets ignored. Because without addressing all of them in somebody living with dementia, we miss opportunities to help them live each day as best as they can and make sure that they have the support that they need. So how can we go from an individual case like Mr. M? How can we take that to the healthcare system and really make our healthcare system age-friendly for people living with dementia? There are many programs that exist for each of the individual M's. And what I've tried to show today is that the 4 M's need to be a set. And so as our healthcare system prepares for the increasing numbers of people living with dementia, as more of us are lucky enough to live to old age, we need to bring these programs together under the age-friendly umbrella because there is synergy when we deal with the 4 M's as a set. I want to share a couple of examples of the early evidence emerging from the age-friendly initiative that shows how it can make a difference in the lives of people living with dementia and their care partners. This study comes from our team at VA Boston, led by Drs. Sarah King and Marcus Rope in collaboration with an interprofessional team you see listed here. We brought the 4 M's of the Age-Friendly Initiative to our skilled nursing facility at the VA, which is known as a CLC, or Community Living Center. Over the course of a year, we formed an age-friendly work group with champions for each M and teams with expertise in that M. We had over 10 different professions represented on our committee. We created a 4M's template that we used for team huddles and notes. And over the course of a year, we implemented the age-friendly initiative. We iterated on it using PDSA cycles, and we obtained recognition from the Institute for Healthcare Improvement as an age-friendly nursing home. Then we studied how we did in terms of clinical outcomes from the year prior to age-friendly compared to the year after. And we published this paper in the Journal of the American Geriatric Society. When it came to our measures of what matters, we saw some improvements in our documentation of life-sustaining treatment wishes and our programs All About Me and My Life, My Story to learn more about our veterans as people. But where we saw the most dramatic changes was actually a huge improvement in falls, behaviors, and potentially inappropriate medications. Compared to the year prior, with a similar case mix of patients, we saw a 34% reduction in falls. When it came to distressed behaviors, which so often are people with dementia unable to express what they need, we saw a 62% reduction, which you can imagine what an incredible difference that made to the patients and the staff in terms of the day-to-day stress levels in the nursing home. Instead of having 5 disruptions per 1,000 bed days of care, there were only 2. And that is a tremendous difference that we've continued to build on. And finally, we saw an improvement in deprescribing events around potentially inappropriate medications. So we could see that on the level of the individual patient, this 4M's initiative was making a difference, particularly for those patients living with dementia. Where we also saw a difference was for our health system. We saw that we actually had a nearly 50% relative reduction in emergency room visits, even though at the same time the VA national average and the CMS national average both increased. Similarly, that was for our short-term rehab. In our long stay, we saw an even greater reduction by nearly 3/4 in our emergency department visits. And so you can see the synergy between the 4M's. We brought together our antipsychotics initiative, our falls initiative, our My Life, My Story initiative to really make sure that we were caring for the whole patient using the 4M's approach. And so the vision that we're aiming towards is that there should be a continuum of age-friendly 4M's care, no matter where older adults encounter the system. And for somebody like Mr. M, who might get diagnosed with dementia while they're living independently, we want to make sure that they receive age-friendly care that aligns with what matters, if they get hospitalized, if they need more care at home, or facility-based or end-of-life care. The 4Ms is a flexible framework that can be adapted to all of these care settings. And I'm very proud to be helping lead the VA's attempt to bring age-friendly across our care setting. We do this through educational initiatives, such as this program, which brings together 10 different professions to do an age-friendly case and learn from one another's professional expertise. And this is all, the program itself is freely available in the supplement of the article, and we're happy to share any of this for teams that would like to implement it. And we're proud that over the past 5 years, we have now reached nearly 500 VA teams across different care settings and across the country who have implemented the 4Ms and received age-friendly recognition. And so what I want to end with is the hope that for every patient like Mr. M, who gets diagnosed with a dementia, that we can provide age-friendly care for him and for his care partners, for his loved ones, no matter where he encounters the healthcare system. And so I want to thank you for your time today and for the opportunity to share this vision with you. And I'm happy to answer any questions in the chat or any questions that come up from our other panelists. Thank you so much.
Thank you so much, Dr. Schwartz. That was incredible. What an amazing overview of really what I think any of us would agree is the gold standard of care. I mean, this is really what we all should be aiming for. I did see in terms of the Q&A, there were a couple of, looks like we addressed those in terms of resources. So I don't know if others have questions or thoughts on either on our panel or from our audience for Dr. Schwartz.
I just ask a quick question. This is a wonderful presentation, Dr. Schwartz. I really enjoyed kind of hearing this, the whole process. And could you maybe just speak a little bit to maybe is there such a thing as an ideal interprofessional team composition? Because it seems like people of different levels could potentially do some of these tasks. Could you just speak a little bit more to the
Yeah,
members
thank
of
you
the
so
team?
much for that question. So there's the ideal and there's the real. And the reality is that there are very few care settings that have access to every member of the interprofessional team that you might want. And so what we need to figure out is, what does this patient need and which of the members of our interprofessional team might be able to meet that need? I'll give the example of medications. Ideally, every team would have a pharmacist on their team to help use their expertise to figure out which medications the patient should be on, and if they're being used correctly, if they can be optimized. But when a team doesn't have access to a pharmacist directly on the team, there are pharmacy resources they can often access through their larger health system. And there is often expertise in other members of the team. I've definitely partnered with occupational therapists to help patients set up a way to manage their medications when they've had trouble opening their pill boxes and setting them up with adaptive tools. I've partnered with nursing who can help set up a pill box and do education to teach the patient. Help teach them how to take their inhalers or how to inject their insulin safely, and make sure that the caregivers are up on the plan. And so we shouldn't let the perfect be the enemy of the good. We should make sure that for most people living with dementia, it's not going to be enough. In fact, I would say for all of them, it's not going to be enough to have one profession, because we need the different perspectives and the different expertise that can help address not only the different M's, but the different medical conditions, the different aspects of care. I find most often when I'm caring for somebody living with dementia, I'm thinking about what sort of support do they need for the mentation M, whether that is a mental health professional or mental health care, whether it's a specialist in neurology or psychiatry, if they've got a more complex picture like a Lewy body dementia, Parkinsonian picture, or if they've got serious mental illness, schizophrenia, in addition to their dementia. So making sure that they've got the appropriate support there. And then often partnering in the mentation M with professionals like speech and language pathology that can do cognitive rehab, as can neuropsychologists, occupational therapists, and others. Often when it comes to the what matters M, I'm also thinking about When should we engage palliative care? Does this person need to meet with nutrition to think about how they're managing what they're eating at home to maintain their muscle mass and be able to do what matters to them? Sometimes, though, the barriers are not knowledge of what to eat, it's that they have bad teeth and they actually need to see a dentist, or that they can't access dental care for financial reasons, and a social worker can help them navigate that. And so, while there's no ideal, perfect team, I think every clinician should go into the care of someone living with dementia with the humility to know that none of us have all of the expertise for everything that comes up in dementia. And so the 4Ms framework is helpful because it reminds us that every profession can address all 4Ms in some way. And when we do our interprofessional workshop in our GREC, we actually have each member, each profession say, if I'm in the medications group and I'm an audiologist, well, maybe I think about which medications are ototoxic, or how important hearing is to being able to understand medication instructions. So I really do hope that every professional listening today sees and feels ownership over all 4Ms and recognizes that it takes a team to make sure our patients' needs get met as a set.
Thanks so much. Those are great examples, and it leads to so many research questions I can see about how to best leverage all the different skill sets of our team. Uh, Well, I recognize we were at the top of the hour, so maybe I'll go ahead and just close this out. Thank you again, Dr. Schwartz, for this very useful framework, I think, to think about how we can support people as they go through the aging process. And Dr. Gately, thank you so much for organizing this session today. And thank you to all of you for participating and engaging. And again, this is recorded, so please share with others. And it's good to see you all, and hope to see you all again soon. Have a great rest of the day. Thanks all.